knee osteoarthritis. So we're going to talk about management, non-operative management. So let's talk a little bit about the burden of osteoarthritis in general. The World Health Organization estimates that worldwide, 10% of men and 18% of women over the age of 60 will be affected by osteoarthritis at one or more joints. The most commonly affected joints are the hands, often the base of the thumb, hip, knee, great toe, the big toe can get very stiff, and the spine. Osteoarthritis is the most frequent cause of disability among U.S. adults. Here's what we're talking about today for my talk. The knee, and out in front there is the kneecap, the patella, and the femur bone is the upper bone, and the tibia bone is the lower bone, the shin bone, and then there's another little bone out there, the fibula. And the important lining inside, the cartilage lining, it's got lots of names. Sometimes it's called articular cartilage, and it's what you see if you eat a chicken drumstick. On the end of the drumstick, that shiny, pearly, grayish white stuff, that's articular cartilage. So what is knee osteoarthritis? Well, it's the loss of the shock-absorbing lining, the articular cartilage, at the end of the thigh bone, the femur, so, right up here, kind of like a cobblestone road, at the thigh bone and at the top of the shin bone, the tibia, and also at the underside of the kneecap. So the body's normal repair mechanism has failed. Over time, arthritis progresses to a rough surface with exposed areas of bone, and on this, you can see these little things that protrude, bone spurs. You've probably all heard of bone spurs, or osteophytes is the fancy name. So on an x-ray, sometimes you'll see these little things protruding. That's part of arthritis. And then the patient notices a stiff and a painful joint. Who is at risk for osteoarthritis? If you're over age 50, if you are or have been overweight, you might have had prior trauma to the knee, or a heavy occupation such as construction. You may have indulged in high level of sports over the years, and it could run in your family. There could be a hereditary predisposition. Sometimes you can really see that with hands, looking at your older relatives' hands. That could give a younger person an idea of maybe what their hands could look like in a few decades. Now, here's the thing, osteoarthritis is not a normal part of aging, but it will become more prevalent as the population ages. We'll see more of it. Osteoarthritis rates will increase as the population becomes more obese. We all know that's a huge problem in the US. There's no cure for osteoarthritis. No agent has been proven to prevent the structural damage to the joint over time. Other types of arthritis, you've heard of rheumatoid arthritis? That's a totally different thing. It's a problem with the lining of the joint that can erode and affect the joint. There are newer treatments for that disease that actually slow the disease progression or stop it in its tracks. So a lot of progress has been made with some types of arthritis, like rheumatoid, but not with osteoarthritis in terms of a cure. What are some of the symptoms of knee osteoarthritis? Well, pain, and it may be worse with activity. Swelling inside the joint, it could come and go. Limitation of motion as the disease progresses. There's something called startup pain. So startup pain is if you sat at your computer or sat in the car or even just get up in the morning, you're really stiff those first few steps, you just hobble. Crepitus, that's the medical term for patients saying their knee grinds, it crunches and it pops and it catches. And another thing, even your family can diagnose, would be deformity. So Uncle Joe, instead of having kind of straight legs or a tiny bit bow-legged his whole life, all of a sudden he looks like he just got off a horse. So that's called varus alignment. That's the doctor term for it, but it's bow-legged. And the other opposite is knock knees. If you wear out the opposite side, the outside of your joint, you become more knock-kneed. And that's called valgus. And also, sometimes patients get really knobby knees, the bones enlarge, and that's because of those osteophyte things. Another symptom could be giving out. The patient will just be walking along or down the steps, and they'll feel like their knee could collapse out from under them. These are just some of the symptoms. How do we manage knee osteoarthritis? I'm going to be talking about two general categories. First is non-surgical treatment, including a combination of non-pharmacologic things, and then talking about medications or pharmacologic treatments. We're going to skip over pretty much all the surgical things. One treatment could be an osteotomy, where you have a bow-legged joint in a younger person. You could realign, take a wedge out of a bone and realign and make the joint straight. That's called an osteotomy. And that's an idea of letting the forces wear out the opposite side and then letting the person get older, maybe get a knee replacement when they're older. So we're going to skip over things like osteotomies and joint replacement. Now, an important topic is arthroscopy. It's human nature to want something to be fixed fast. So a lot of times a patient will come in, and sometimes their primary care has ordered an MRI, and on the report it says they have a torn meniscus, torn cartilage. And so, of course, their natural inclination is, well, okay, take out my torn cartilage, fix my knee, and then I can carry on. But arthroscopy studies that are well-done studies show no long-term benefit to washing out and just debriding that joint with a scope. So in most patients, I'm not saying 100%, but in most patients with significant arthritis, arthroscopy is not warranted, even if the MRI showed a torn meniscus. Because the torn meniscus is a tiny problem, the arthritis is the big problem. I know that's disappointing to hear. We all would like, the doctor to be able to do a quick little thing and then you're fixed. So we have this discussion. I probably have this same discussion several times a week with people, and it's hard for them. On the left is a knee replacement where the end of the thigh bone is covered with a metal component that fits like a glove, and the top of the shin bone is covered with a metal component. And in between, you can't see it, but there's a polyethylene liner between the two pieces of metal. On the other side, the other knee, this knee is wearing out. Now, you can see on the inside of the knee, the space is very narrow. On the outside, it's got a better space. So we don't need an MRI to figure out this knee. This is wearing out, and there's some little tiny osteophytes here. Do you see how the bone is whiter here? More of the forces have been going through, the body weight has been going through that inside part of the knee as the knee collapses into that bow-legged position. So more weight goes through here, and the body responds and makes the bone stronger there. So what are some patient-specific reasons to delay or avoid a knee replacement? Well, they might be too young. So if you get a knee replacement when you're 40 or in your younger 50s, if you live to be 80 or 90, that surgery will not last the rest of your life. So you're already going to be getting that revised. Old age could be a reason to not do it. If you're a really frail person that can't stand out of a chair, has really lost the ability to walk, with limited rehab potential, that might be a reason that you don't get a knee replacement and you try to treat the arthritis another way. Morbid obesity, that's a big problem in the country. So if you're too heavy and you're too young, that knee replacement will fail pretty quickly. Other medical conditions may need to be improved before you get your knee replacement, such as diabetes or high blood pressure. Another condition where a patient might think twice would be a history of blood clots. So deep venous thrombosis that could kill you post-op. So some people might think, wow, I don't want to take the chance, so I'll just live with my arthritis. Another category is a cancer patient who's undergoing chemo. Their immune system is compromised, so you don't want to be challenging it with a big procedure at the time you're going through that treatment for the cancer. Another problem would be a chronic infection. So if there's some infection in your body that hasn't really been able to be completely eradicated, putting a foreign body, the knee replacement in your knee, could be at risk to get an infection there. And then finally, cognitive ability. So if a patient is not able to fully participate in rehab, getting the motion back, getting strong, then probably they shouldn't do a knee replacement. So what are some things to offer the patient who's not getting a total knee right now for whatever their reason. One is activity modification. A next would be talking about weight management. A third would be physical therapy, going there to learn exercises to do at home. And then another category is a brace with hinges or an unloader brace to support the arthritic joint. We'll talk about each of these. Activity modification, you want to lessen the impact on the joint from just walking every day of the week, possibly use the elliptical or a stationary or recumbent bike or work out in the water. So cardio exercise is good for you, so your doctor may tell you, well, you can't do so much walking. That doesn't mean quit all cardio, it just means pick something different. For kneecaps, they can walk on level ground. If your kneecap is arthritic and the rest of the joint is okay, you just want to avoid deep squats and lunges and hiking and walking hills and steps, but they can walk on the level ground. What's the place in this town that or some people are addicted to? Badger Mountain. I probably have to have the Badger conversation once a week. So if their knees are killing them, especially their kneecaps, and we find arthritis, we have to talk about Badger Mountain. And I'm not against Badger Mountain, but running down Badger Mountain is the really hard thing. So what else? Cross-training, that's what we just talked about, choosing a variety of exercises and mixing it up. And the last thing, don't be a knee abuser. Hiking and running up and down Badger or just being a jogger or walker 7 days a week, that's probably going to take its toll. Weight management. Once the knee osteoarthritis has begun, being overweight or obese may accelerate the disease progression. The kneecap bears 4 to 5 times the body weight because it's a fulcrum effect with your quad muscles. So when you're climbing and up and down steps or getting off a couch or out of a car, that kneecap is working, doing a lot of work. So for every 25 pounds lost, they're going to reduce the load on their kneecap by 100 pounds. Makes a big difference to carry the groceries up the steps. So here again is a reminder, this kneecap out front is attached to the 4 quad muscles. Here's a front view and here's a side view. And I'm sure there's lots of retired engineers in this room that could explain the whole fulcrum thing better than I can. But the way the kneecap is sitting out in front of the joint, it provides a lever arm. So here's the attachment on the shin bone, and here's the muscle up here, and this being out in front gives it a little more leverage and lets more force go through there for the quad to act. Okay, physical therapy. So we don't want you to go to the therapist forever. We just want you to go in there and learn 10 to 15 minutes, a home program that you can do. Patients sometimes just want me to show them or just say, can I go online and do it? But I think there's a lot to be said for a person there with you, teaching you each exercise, and then giving you a little reminder handout on how to do them. So even if patients don't want to go several times, if they go at least once, they'll be on the right track. The physical therapy will not reverse the arthritis. Remember, we can't cure arthritis, but it will strengthen the quad and the hamstring muscles in your thigh, along with hip muscles, and it will work on flexibility in the lower legs to counteract the stiffness and the loss of function. Patients often complain that if they're on the floor to clean the floor or to play with grandchildren, they can't get up without using their arms to pull their weight up. And that's really the goal of this program, get your muscles back so you can stand up without being stuck down there and somebody helping you. And if you stick with these exercises for a few months, you'll notice a difference. Here's some basics. The therapist will give you some harder things. Now, bracing. A simple wrap or a neoprene sleeve may make a patient feel more secure. A hinge brace might be a help. And then there's something out there called an unloader brace. So an unloader has hinges on both sides, and it's designed to transfer the weight from the worn out side to the side that's still good. They come off the shelf, kind of pre-measured, and then the place that we send you will fit it to you. And if you're not kind of a standard size leg, you might have to get a custom one made so that it fits correctly. Some patients really love these braces, and others who have tried them don't tolerate the brace very well. Here's an example. So I don't know how many people will be happy running around all day on one of those, but sometimes people get a lot of relief, so it's a choice. Now we're going to move to the drug aspect of treatment, pharmacologic options. Over-the-counter drugs, we'll talk about those. We'll talk about glucosamine, chondroitin sulfate, prescription non-steroidals, COX-1, the standard ones, and Celebrex, COX-2. We'll talk about cortisone injections and lubricant injections. Okay, over-the-counter drugs, ibuprofen is kind of the standard one out there. 200 milligrams, that's the standard tablet that you buy. 1 to 4 times, one, 2, 3, or 4 tablets, depending on your weight and your health, etc. Your doctor could guide you, but you would be taking it 3 to 4 times a day with food around the clock. Now, the big risk is to your stomach. You could have a bleeding ulcer, you could have stomach aches with long-term use. Even short-term use, there is some risk if you're over 60. Another drug out there you don't have to take as frequently, it's called naproxen or Aleve. It comes as 220 milligrams. It's labeled 1 tablet twice a day, so you're assaulting your stomach less often. And a lot of times, depending on the patient, we might tell them they can take 2 twice a day. It has the same risk to your stomach. Capsaicin cream, it's a topical aspirin product over the counter. Some patients like that. And then Tylenol doesn't have the stomach risk. Tylenol about a year ago got remarked. You're not supposed to take 4,000 milligrams a day. They lowered it to 3,000 for fear of hurting livers. So that's really only 6 extra strength tablets a day. So if you have stomach ulcer history, that's an option. Nutritional supplements. The most commonly used, you can see it all over Costco, would be glucosamine, chondroitin sulfate, joint juice, all the different brands. There are no good studies that prove that these supplements work, although anecdotally, some patients swear by these as helping. The supplement is in dogs' food, it's in racehorses' food. We don't know of any harmful effects, but we don't have proof that it works. So I think you have to use your own judgment if you want to try that for a few months and see if it helps you. Prescription non-steroidals. So these are all what's called COX-1 inhibitors. They work to stop inflammation at a common step in the pathway that leads the knee joint down a path of swelling and pain and stiffness. These drugs reduce symptoms. They don't stop the disease. Examples, I just pulled out a few examples. I don't have any allegiance to these 3, but you might have heard of diclofenac, which is Voltaren, Atodolac, Lodine, Meloxicam, Mobic. They're in 7 different categories, so if you don't do well with, say, naproxen, your doctor could try one from a different category. And sometimes one helps one patient, and it might not help another. They all have the same risk, stomach ulcers and bleeding. There are some topical ones out called Voltaren gel and Pensed cream. They have slightly lower risk to your stomach, but they still have some risk. The long-term use of any non-steroidal can affect your kidneys, so patients with high blood pressure and diabetes are at a higher risk of kidney damage. So if we have a patient taking those and getting refills, we might be asking you to go get your kidney function checked, just get a blood test, so we don't hurt your kidneys. There's another category called COX-2 inhibitors to reduce inflammation from osteoarthritis. They have a lower risk of giving you a stomach ulcer or bleeding, not 0, but lower. The only one currently approved in the US is Celebrex. Everybody's heard of Celebrex, right? Okay. And many insurance plans require that you've tried the basics before you start something like Celebrex, which is more expensive. Another option is a cortisone shot in your joint. These help within a few days and they can last for several months. You can only have 3 per year, and there's no role in oral steroids like prednisone every day to treat knee arthritis. So we often mix a little bit of numbing medicine that works right away, one that lasts 3 hours, and the cortisone, the triamcinolone. So we mix it into one syringe, and that's what the shot is. I'm sure a lot of people have heard of the chicken the chicken comb injection, the viscosupplementation, so hyaluronate. These have just become controversial again. They've been around since the late 90s. So it's a preparation of a high molecular weight polysaccharide that's a component of the cartilage in your joint and the synovial fluid. So I listed some of the brands. They have differences in their molecular weight, their viscosity, whether they came from the rooster comb or from bacteria, whether they're cross-linked, and how many shots you need. The success rate quoted by patients is 50% respond. So we don't know ahead of time before we do these expensive shots if you're going to respond or not. Now a new trend is the Academy of Orthopedic Surgeons did a huge study looking at all the different manufacturer studies, and they decided it's not 100% sure that it helps enough to say everybody should run and get these. So I know Primera, as of April 1, is not going to pay for them anymore. And I don't know if Medicare will follow. So again, this is what we're trying to help the lining of the joint. And here's some of the brands, these lubricants. Now I have just a few more slides. Individual treatment plans. So if you think that you might have osteoarthritis, your primary care or an orthopedic can look at your knee and order x-rays. The key thing is you want a weight-bearing x-ray. And an MRI is not routinely needed. In fact, it may be a distraction to the treatment. Remember I talked about the torn meniscus kind of leading you down the path that you think you can be cured with a knee arthroscopy. So x-ray and exam, that's the starting point. Your orthopedist would assess your limb alignment, your range of motion, your stability, swelling, where you're tender. And they'll also screen out a hip problem, because sometimes a hip problem hurts in the knee, or your low back could mimic a knee problem. Your orthopedist will review your knee x-rays to determine the pattern. Is it around the kneecap, the patella? Is it medial or lateral, or is it in several areas? And then tell you, is it mild, is it moderate, or severe? Here's an example of a bum kneecap. That's called a sunrise or a skyline view. See the space here? And here it's rubbing. And this is a side view. This poor kneecap is just ground down. It's lost its lining. So your orthopedist will take into account your age, your activities, your goals, and then start a treatment, an individual plan for your knee arthritis. And that could be some suggestions from the non-drug treatment list that we talked about, and then a discussion about what medications you might try. So I'm done, and I see Dr. Gibbons made it. He was in the OR earlier.
So to start off, what I'll talk about today, talk a little bit about the shoulder anatomy. Okay. Common conditions and diseases that we see, some exam findings that you may feel that your primary doctor, or if you've had a referral to an orthopedist, they may undergo this exam. So you'll not think we're crazy when we're doing these weird maneuvers on your arm. Treatments, and then at the end we'll have a period for questions, as was mentioned. So the shoulder girdle, we call it, actually is comprised of two joints and a pseudo joint. There is the glenohumeral joint here between the humerus and the scapula, that's the glenoid. There is the acromioclavicular joint here between the clavicle and the acromion, that's part of the shoulder blade. And the third articulation is not really considered a true joint, but it's a pseudo joint. There can be problems there. It's the scapulothoracic articulation, where the shoulder blade rubs against the back of the chest wall. There's, as I said, it's not a joint lining, but it has muscles between, and there can be problems that come up with those muscles of the shoulder girdle. So the main bones are the scapula, the clavicle, the humerus. A lot of little processes here that make up the shoulder joint where muscles attach. We talked about this. Oh, I didn't talk about the sternoclavicular. This is down further where the clavicle attaches to the sternum, so that's actually where the shoulder attaches and the arm is attached to the body. Without the clavicle, you kind of have a floating arm. So it's kind of important to have that clavicle. Muscles. There are 17 muscles that attach to the scapula. Most people think of the rotator cuff. You've probably all heard of the rotator cuff. It's a group of 4 muscles that go from the humerus to the scapula. There are 13 others. Any one of those, if there is a dysfunction to that muscle, can cause dysfunction to the shoulder girdle. And the course of non-operative treatment, specifically therapy, focuses that I send people for. I focus specifically on what I call scapular mechanics and the scapular musculature, because as I said, any one of these muscles is trying to compensate for an injured muscle and can throw off the entire shoulder girdle, which can then give you pain, give you dysfunction, and cause major problems. The shoulder joint itself is not quite as stable a joint as, say, the knee joint or the hip joint. It is the most mobile joint in the body. People sometimes think of it as a ball and socket joint. I describe it more as a ball on a golf tee. And you see how unstable that ball sometimes is on the golf tee, especially on a windy day. So all of these ligaments here are what help keep the shoulder joint, the humerus within the joint. The muscles also help, but the ligaments are what help keep it stable as we put it through all the different places we put it in our daily lives. This labrum here is a lining of cartilage around the outside of the cup, and that's where all these ligaments attach. One of the main tendons, the bicep tendon right here, comes in and attaches onto the labrum. And in this cross section, you can see the tendons. There's the supraspinatus, infraspinatus, and teres minor, subscapularis, but then you see all these other ligaments around that help stabilize the shoulder. Also within the shoulder joint, and we'll talk about this again a little bit later, cartilage and the bone that wears out with the arthritis. These are standard AP view, has a special name called the Grashy, but that one allows me to look and see the joint itself. You can see this nice rounded head there, nice glenoid there. There's no bone spurs there, no narrowing. That's a really nice looking shoulder. This one here is an axillary view. So if you ever have that one, what they'll do is they'll put your arm up on the table and shoot an x-ray beam up under your armpit. An MRI of the shoulder. This is an individual who came with an MRI, and a very nice MRI, so it's a good teaching MRI. But this is, again, the humeral head here. Here's the cup here. That right up there is the acromion, or the top of the shoulder blade. Then right in here we see that top rotator cuff coming through here and attaching out here on the humeral head. That's a nice looking rotator cuff. This is a cross-sectional view. So some common conditions that patients will come to see me or the primary doctor or any other orthopedist for in the shoulder. Most common rotator cuff impingement. You may have heard bursitis, you may have heard tendonitis, one and the same in my mind. It's a spectrum from the impingement on up to rotator cuff tear. A lot of the symptoms will mimic each other. The treatments are very similar until we get to the point where we're talking needing operative treatment. Calcific tendonitis is a condition, we'll talk about this a little bit more, but it's a condition where, it's a rotator cuff condition where your body lays down calcium within the tendon. It can be very painful. Long head of the bicep tendon tear or tendonitis goes through the rotator cuff. I have plenty of patients who will show they've lifted something and tear their bicep, and we have a discussion about how to treat that. Adhesive capsulitis or frozen shoulder. Then at the end we have arthritis, and the two types of arthritis I describe to people. The standard run-of-the-mill arthritis and this rotator cuff arthropathy is where it's probably the big bad granddaddy of them all in the shoulder. Really dysfunctional, really painful. Not only have arthritis, but you also have a major rotator cuff problem. So impingement. Getting back to our anatomy, we have the clavicle up here, we have the acromion, which is the end of the collarbone, and right in this area here, this little gray area represents the shoulder bursa. And there's a bursa between the acromion and the rotator cuff that allows for smooth motion in there, but it also allows for inflammation and pain if there's something that causes a problem. Usually there is, when I see someone with impingement, they describe an overuse type injury. They describe an injury where there's been a fall, or someone hit them or something like that. The main complaint is pain, difficulty reaching overhead, and weakness in the shoulder. And this here, again, showing some examinations findings that, again, when your doctor does this to you, you'll say, okay, now I know what we're doing. Looking for this impingement. On this picture here, what we're demonstrating is as you reach up overhead with a straight arm, you'll feel pain there in the shoulder. That can indicate that that tendon right here, as the rotator cuff comes through here and attaches, that can indicate that that tendon is getting pinched between the acromion and the humerus. Again, if you think of something soft being pinched between two hard surfaces, that can be pretty painful. This Hawkins sign here down on the bottom, again, another test for impingement. We rotate your arm down, again, trying to elicit that tendon getting pinched between the two bony surfaces and causing pain. The x-rays here showing, this is an x-ray I'll get looking for impingement. The acromion has a different shape. There are 3 different types that have been described, a type 1, 2, and 3. Any type of those can lead to impingement, but people who have this type 3 are a little bit more predisposed to the impingement. So treatment of the impingement, what I recommend is we start off with a non-operative treatment. Being a surgeon, I like to operate, but it's always best to start non-operatively because 80 to 85% of the time we can have success with non-operative treatments, and if we can avoid a surgery, that's best for everyone involved. Starting off with the physical therapy, I will recommend either a home program where we'll give you some exercises in the office, or a directed physical therapy program with a therapist. And again, as Dr. Scovazzo mentioned in her talk, a therapist is a great benefit to give you the direction. I'll often have patients go in for a week or so, and then they'll come back and they'll go in once a month just kind of as a refresher, just to make sure they're doing the exercises correctly. The goal with the therapy program is not necessarily to change what's going on with the bone spur, because obviously we can't do that. It's more to work on those other 17 or other 16 muscles of the shoulder blade to try and change the mechanics of the shoulder, get it back to normal, and minimize the impingement by strengthening the shoulder musculature. Also, we have cortisone injection, similar processes in the knee, mixing up that little cocktail of the cortisone and the local anesthetic for most likely short-term relief, but occasionally we'll have patients who do get some long-term relief from this cortisone injection. Activity modification can be important. If you have someone who's doing a lot of overhead activities and that's what's causing the problem, I have a frank discussion with that person saying, listen, is this overhead activity extremely important to you? If it's not, that might be something you want to give up, because the easiest way to avoid surgery, if there's a specific thing that's causing the problem, stop doing that activity. And time. A lot of times with this, just giving it some time with these small measures will improve the symptom. That time can be anywhere from a couple months. I have had some patients where it'll stick around for up to 6 months, but a lot of times it will get better. If it doesn't get better, that's where we come to the operative treatment. And there are, the treatment of this is to go in and remove that bone spur. Some surgeons will do this open, where they'll make an incision on the shoulder. I do it with an arthroscope, where we'll make a three small incisions and use a camera and little tiny instruments to go in there and just shave things out. And here you can see a before and after. This is my instrument there. It's a metal instrument. You see it's flat there. It's sitting on the bone, and the spur just kind of drops off like that over there. Rotator cuff tear. That's the next on the spectrum of rotator cuff disease. Symptoms are very similar: pain, weakness, and loss of motion. I do occasionally have patients who come in and describe nerve symptoms of nerve pain going down the arm, nerve pain going up the neck. And that can be from the nerves around the shoulder girdle. If that's a big tear and is pulled back away from the head far enough, that can actually put tension on those nerves and give referred nerve pain. One way to specifically test for that, this Jobe's test or empty can test, that's going to be testing strength. I bring someone's arm out in front of them at an angle like is shown there and push up against resistance. That is the motion and the test for strength specifically for that supraspinatus tendon or the top rotator cuff. This internal and external rotation test down here at the side is testing for the infraspinatus rotating out and the subscapularis rotating in. So the rotator cuff tears, you can have a partial thickness or a full thickness tear. And again, coming to this MRI, you see the cross section here. Here's the muscle there, and the tendon comes out here, and you see it gets really thin right there. Just kind of a little pinhole right there, but probably not completely torn all the way. But you do see a little bit of fluid above there. So that something like that tells me it's either a very significant partial thickness or a small full thickness tear, and we'll see that. We'll then talk about the treatment options. The bottom picture here, you see a full thickness tear. Here again, you have the muscle coming through. There's a clavicle. Here's the head. And you come out here, and there's just this gap. You see that it's been separated. It should be out to there and attached there. You have that gap. I've seen that's actually, as a tear, it is a full thickness, which in my opinion, any full thickness tear is not a good one. We mentioned here traumatic versus degenerative. Those are mainly the two ways you're going to tear your tendon. Traumatic can be a fall. It can be something jerking on your arm. It can be a direct blow, though that's less likely. Degenerative just wears out over time. Sometimes we see someone with a big spur, and I go in there and the tear will be right beneath that spur. There's argument whether the spur will cause the tear or whether it's just associated. I've seen some that look like a saw and directly below, and I'd say that's probably at least part of the tear, but I can't ever say it's the spur that caused that. But usually with the degenerative, you're going to see someone who's had the chronic tendonitis, chronic shoulder pain, and finally over time they just reach out and the tendon gives on them. So with a partial thickness tear, the treatment's going to be very similar to the treatment for impingement. We're going to start off with the non-operative treatments with a physical therapy, cortisone injection, and giving it some time. And with this, generally, I'm a little bit less conservative with waiting a long time. If someone's not improving within that 1 to 3 month time frame, they're probably not going to improve if we give them another 3 months. So that's someone that we'll sit down and talk. Is this bad enough to consider that surgical intervention? Where we go in and do that decompression, we'll shave out that spur, open the space up, and in several cases there will be some sort of rotator cuff repair, whether it's a repair where I have to repair the whole thing or just repair the tendon back to itself if it's a partial tear. With a full thickness tear, again, non-operative treatments. Some patients, I didn't put this slide in, but I really like that slide of Dr. Scovazzo's where she mentioned the discussion we have about, is someone able to tolerate a surgery? Any rotator cuff tear can be fixed, generally. There are some that are pretty hard to fix, but sometimes the patient is not a good candidate for surgery, whether it be someone who has really severe heart disease or really severe medical problems, or someone who just is not able to participate in the rehab. One other thing that I'm really careful with these is I've had a couple patients who we talked about and we had this discussion. They said, yep, I can be really compliant and not use that arm. Well, then something happened and they ended up in a wheelchair. That's kind of a bad thing to do because you have to have your arm to propel the wheelchair, and that kind of throws off the healing of that tendon because we have to allow that tendon time to heal before we can really use that arm. So someone who's in a wheelchair may not be a good candidate for a rotator cuff repair simply because you have to be able to immobilize that arm to allow it to heal. With this one, with a full thickness tear, someone who wants to try non-operative treatment but is a candidate for operative treatment, usually again a shorter time of waiting, 4 to 6 weeks, and then we'll say, okay, let's go ahead and fix that. If someone comes in and they're really debilitated and says, we got to get this done right away, we'll do it sooner. So the operative treatment, again, arthroscopy versus open. I try to do these all arthroscopic. Some surgeons will do a mini open or a complete open where they'll make a small incision to visualize the tendon. My own training and my own feeling is I think I get a better view of the tendon. I feel like I can mobilize the tendon a little bit better with the scope. So I try and do it all arthroscopically. This is a picture of the rotator cuff here. You got to kind of stand on your head for this one. It's one. My partners come in and watch me occasionally when we just joke around with each other, and they have to come in and stand on their head because I do it upside down, just the way I hold the camera. But this is the humerus up here. The patient's head is actually down here. the arm is going this way. So this is the rotator cuff. We want to take this tendon and pull it back out here, and you can see the bone there. There's the edge of the cartilage right there. We call this the footprint. That's where it's pulled away, and that's what we want to get that tendon back down to so it will heal to bone rather than trying to get it to heal to cartilage, because it won't heal there. If I see a big tendon that won't pull all the way out to the bone, or if there's a problem like that, that may be a tendon that's not repairable. But here you see the final repair on that tendon. Here's a couple knots over here. You kind of get appreciation. There's a couple knots over here, but we've now pulled, there's the end of the bone there. We've pulled that tendon back out, and it's covering that footprint. That patient went on to heal this very well and did very well. Calcific tendonitis, another rotator cuff problem. The way I describe it for patients is that at some point in your life, you had an injury to your rotator cuff, and your body decided, hey, I'm going to lay some calcium down there. Sounds good. Basically, it's a mixed signal. Instead of healing with normal tendon tissue, a normal collagen of the tendon, it'll lay down calcium. And you can see in this spot here, there's some calcium right there in the supraspinatus tendon. Can be very painful. If you think about that, it's not calcium that's hard like the bone, but if you think about the impingement we talked about earlier, you lift your arm and you're pinching a soft tendon between two hard bones. Here you've got a soft tendon with something in it, pinching against two bones. That can be pretty painful. The exam, the symptoms, pain, 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 pain. There is a lot of weakness with this as well, loss of motion, and patients will present often very similar to the rotator cuff tear. And even on exam, we'll think, okay, there's a good chance you have a rotator cuff tear. We look at the x-ray and see, oh, there's calcium there. Okay, it's just calcific tendonitis. Trying non-operative treatment. This is not a torn tendon, so we can have success with non-operative treatment. Again, physical therapy, cortisone injection. I put that 1% to 2% or less than 2% there because the cortisone injection is a little bit less effective here. I have had occasional patients where I give them the cortisone injection, and for some reason we get lucky and it causes the calcium to dissolve away, and they're able to function normally after about 2-3 months, and they return to normal life, and we say, hey, that was a win. So I will always try a cortisone injection, hoping that we can get that patient into that 2%. Again, time there. This lavage here, excuse me, I don't do it myself, but one of my partners that uses an ultrasound where he'll go in and he'll come right in here with a needle and put the needle right in the center of that calcium, and he'll just inject some fluid, withdraw, inject fluid, withdraw, inject, withdraw, get as much of that calcium out as he can. And he tells me he has about a 60 to 70% success rate with that, where he can make it smaller. He may not get it completely taken away, but we'll make it smaller. And if we can make it smaller, hopefully that will help take away the symptom and make someone feel better. If all else fails, all our non-operative treatments fail, we then get into the operative treatment of that. And again, we go arthroscopy versus open. What I do is I take out this nidus of calcium, and my indication there is, again, here's the rotator cuff, but if you remember back here, even the torn tendon was still shiny and white there. We come here and you see this is what I call a cherry red spot, and that indicates to me that that's exactly where the calcium is. In fact, I did one of these last week, and that's exactly what I saw. Got in there, and there's just this red spot right on the tendon. Unroof that, and you see this calcium, and it looks just like toothpaste. I can squeeze it out like toothpaste, but basically I just clean that up. A lot of times it will leave a defect in the rotator cuff because it's been in the cuff, and sometimes we have to repair that. And when I say sometimes, it's probably greater than 90% of the time. If I take out the calcium, I do have to do some sort of a repair of the rotator cuff. Bicep tendon tear, also pretty common. Usually this is a traumatic event. Someone will remember they were lifting a piece of furniture. They fell, reached out to grab themselves and jerked their arm. Felt a pop in the shoulder, pain, swelled up, bruising, and then later they noticed this deformity here, this Popeye deformity. They also can have some cramping. The nice thing about the bicep is it has two tendons up at the shoulder. There's one tendon down at the elbow. If someone were to rupture the bicep down here at the elbow, we need to fix that. Or else they'll have loss of function. Up at the shoulder, because there are two tendons, a lot of times we can let that go. If someone isn't bothered by that deformity and they function well and they don't mind a little bit of cramping, usually goes away after a few months, then we can treat that non-operatively very well. I don't know how many of you are sports fans, but those of you who are may remember John Elway. He ruptured his bicep. I've tried to find the picture of it. I saw it in a talk once. I've never been able to find it. On his throwing arm, and went on to win 2 Super Bowls. So that just kind of shows you that this bicep, you can be very functional, very highly functional after rupturing that bicep. So then we have the discussion with patients of, do we fix it? The discussion I have is based on age and activity level. Someone who is younger, who is an overhead laborer, farmer, construction worker, doing a lot of overhead, a lot of reaching, a lot of activities where it requires twisting, pipe fitters, that's a person that I'll say, you know what, you might be better off to get this fixed. Someone who's a little bit older, or even someone who's younger, who has a more sedentary job, whose activities don't require a lot of use of twisting and reaching and overhead, that's someone we say it may not be worth it to go in, make an incision there, try and find that tendon and reattach it. So that's a discussion to have with the orthopedic surgeon. In testing that, there's specific tests to test for weakness. I'll always push right there on the tendon itself. If it's painful there, this Speeds and Jurgensen's test are just 2 maneuvers I can test to see how deficient your arm is with that bicep. Does it cause pain? If you've ruptured the bicep and those aren't painful, then it's unlikely that other activities will be too painful and you'll have too much problem with the bicep rupture. Another shoulder condition is adhesive capsulitis or frozen shoulder. This is one that's actually often confused. I'll have a lot of patients sent to me for a frozen shoulder. They've never had an x-ray. I get an x-ray and we say, actually it's not a frozen shoulder, it's arthritis. But this is one we want to think about, especially in younger patients, but it can develop in anyone. There are 2 types. There's idiopathic and there's traumatic. Idiopathic we don't know why it's caused, but we know it's associated with women in their 40s or older, and diabetic patients. Just causes the capsule to get a little bit thicker and you lose that motion and it's very painful. With traumatic, usually if there's been an injury to the rotator cuff or to the labrum or post-surgery, one I didn't put in there is after fracture. I do see that often after a proximal humerus fracture. We've immobilized the patient for several weeks while that's healing. Things will tighten down and they will scar in. There are stages to this adhesive capsulitis, and it'll take anywhere from 6 to 24 months. If someone's patient and doesn't want to have surgery, we'll wait the whole time. If they're more aggressive and want to get this taken care of sooner, we'll consider intervention sooner. But there's a painful stage, and it can be painful throughout. It may be someone who's just painful initially. Pain can be anywhere at any one of these stages or any specific period of time. It's the freezing stage where you start to lose the motion. Still painful, and you say, well, you know, I'm losing motion, but I can still function. Frozen, I get patients who come in, they're frozen, and they just are not moving. The shoulder, you try and move the shoulder, and it's just like there's a mechanical block there. And then the thawing stage where things are loosening back up and getting that motion back. With the exam, the main thing is the pain and the loss of motion. Most commonly in rotation, rotating back this way and rotating back behind, people will complain of not being able to get back to tuck the shirt in, to fasten the bra in back, wash the back, reach across the body to do deodorant or wash your other shoulder. That's frozen shoulder. But again, it's often mistaken arthritis is often mistaken for a frozen shoulder. So treatment for this, non-operative treatment, a lot of therapy again for stretching. Strengthening is not going to do a whole lot. The main thing with therapy is you're really going to stretch things out. Steroid shot. The steroid itself is not going to help loosen things up, but it hopefully would help with the pain so that you could get more effect out of the stretching. And then for operative, we have the manipulation, where we just take you to the operating room, put you to sleep, break up the scar tissue, and occasionally that's not enough and I have to go in with the scope and actually surgically release the scar tissue. Arthritis, coming right after that one. You can see this, you remember back to our shoulder picture earlier that had a really nice joint space. Here we see the clavicle, we see the acromion here, and you see bone on bone between the humerus and the glenoid. You see a big bone spur down here on the glenoid, a big bone spur down here on the clavicle, or on the humerus, sorry. The other thing we see here is some flattening of the humeral head. This should be nice and rounded. It's still round, but it's a little bit flatter than it should be. On examination, this is what I'll find, this is what people will complain of. They'll complain of loss of motion. They'll complain of pain. Grinding. People say that it just feels like there's something in the shoulders. I try and move that shoulder. It feels like it's just a cogwheel, or it feels like there's sand in there. It just feels bone on bone. The strength is usually very good. People don't have good motion, but when I test the strength, they've maintained the strength. With non-operative treatments, with arthritis, we'll start off with the steroid shot, the activity modification. Now, Dr. Scovazzo talked about those lubricating injections. Those have not been approved for the shoulder. I think I've used them probably a half a dozen times, but it's always off-label, so it's not something we do on a regular basis. And then medication, the anti-inflammatories, the ibuprofen, the Aleve. If those don't work, on up to the Celebrex and the stronger ones. And then the therapy, I always tell people the best therapy for you with arthritis is to be active. It's going to be painful, but be active. Working with a therapist can help, but the main thing here is to maintain your strength. You're not going to really regain a whole lot of motion with that. Your bone on bone, it's just grinding, it's crunching, it's those bone spurs stop the motion. So there's not going to be a whole lot of motion regained. Operatively, and this is where I came from today, we're going to do a shoulder replacement, where we come in here, we take off the arthritis on the humeral head, we take out the arthritis on the glenoid, and then we put this metal stem down the humeral head with a metal cap. And then over here on the glenoid, you can't see it. That little line right there is a little metal peg inside the glenoid. It's all that polyethylene. It's the very strong plastic that we put in there. We found that metal actually on the glenoid doesn't do well, so we just cement in a piece of plastic, and patients do pretty well with that. The final one we'll talk about today is the step up from just your standard arthritis. This is the rotator cuff arthropathy. So here we have the combination of the bad arthritis, the bone on bone. You have a massive rotator cuff tear, and this picture doesn't go all the way back, but if we watch that, you can see the tendon here, but there's really no muscle left. When I see someone when I'm seeing someone for a rotator cuff tear, and if I see there's really not a lot of muscle, that's someone we have the discussion. This may not be a repairable tendon. We may just want to go the other treatments until we get to this point. But oftentimes someone who comes in, the rotator cuff tear has been so long standing, it's not repairable. And that's what happens here. The other thing we see is some high riding of the humeral head to the point where we've started to remodel that acromion. You can see that's now curved. Your body's starting to create a socket joint there, which is why this person comes in and they can't move their shoulder at all. I knew that was going to happen, darn it. I had a little movie here of a patient that demonstrated that. But the exam findings are loss of motion, and most times patients can't lift their arm even much higher than chest level. The rotation's also very difficult, but then I can take them and I can lift their arm way up here. They have good motion passively, but then as soon as I let it go, their arm just drops. That's that drop arm test. That just tells me that the rotator cuff is not there, it's not functional, and along with that arthritis, we've got this rotator cuff arthropathy. And then this pain and crepitus, that crepitus is the grinding. And I had that, I wish that would have come through. Non-operative treatment for this, Again, steroid shots, activity modification. This is something we often see in very senior patients. And as, unfortunately, as you all know, as we tend to age, we tend to develop more health problems. And so this is one where we'll have more of a discussion with patients of, can you tolerate surgery? It is a big surgery, it is a big recovery, but in more very senior patients, the health conditions may not allow you to have that surgery. So we'll be doing these activities. I have a handful of patients where they'll come in every 3-4 months and we'll give them a shot. And that's what we've got to do, just because they can't, their cardiologist or their pulmonologist or their primary doctors just told me, no, they're not going to tolerate a surgery. Activity modification, pretty hard to modify your activity when it's already modified by the shoulder, but we try and do our best. And then medications, and again, be active as you can. This other video is not going to go through either, darn it. The operative treatment, reverse shoulder replacement, is called reverse. This is one case where I will put metal on the glenoid side, and you can see what I did here is we switched sides. We put a little metal peg here and put the ball over on the cup side, and then we put a longer stem down and we put the plastic over, you can't see the plastic, but we put the cup over here on the humeral side. What that does is it allows the big deltoid muscle to take over for the rotator cuff. It's not as efficient because, again, getting back to the fulcrum and mechanics and everything, what it does is it lengthens the deltoid and allows it to be the one to help lift your arm. It's not as good as the rotator cuff was originally, but well enough that if we'd been able to see that picture, this lady, the before and after, she could only lift to here. The after, she was able to lift up to here on her own power. She did very well. I do have some patients that only get to eye level. I always tell my patients with this particular procedure, if we can get you somewhere between eye level and overhead, I call that a win. The other big thing for this one is pain. Even if we can only get you to here, but we take you pain-free, that's another win. So that's our goal there is treatment of pain and secondary goal of improving the motion. And that's all I have.